Hello and good evening, everyone. Yes, so welcome to another live session on Idento. So, how you guys doing? I hope all of you are fine and doing well. Yes. So, for the past 2 weeks, we had been studying dental anatomy and oral histology according to our NEET MDS schedule. So today we are going to discuss some of the very important multiple choice questions from dental anatomy and oral histology. All right. So most of these questions that are included in this session were taken from the recent NEET MDS exams. All right. Why recent NEET MDS exams? Because then only you will know the pattern of the questions that were asked for the NEET MDS exam, and you will understand the difficulty level and the high yield topics of dental anatomy and oral histology. All right. Okay. So dental anatomy and oral histology, as you all know, it is a basic science subject, and you can expect an average of 14 questions from DADH for your NEET MDS exams. Usually, like 4 to 7 questions can be asked from dental anatomy, and 5 to 8 questions on an average can be asked from oral histology. Definitely, there will be change in the number of questions also. But usually, yes, this is the expected number of questions from dental anatomy and oral histology. It is a scoring subject, very easy to retain subject. So if you are really careful while answering the answers, then definitely you can score full marks for all the questions that appear from dental anatomy and oral histology for your NEET MDS exams. Okay. First year subject, basic subject, very easy to understand subject, easy to understand the concepts, and easy to retain also. All right. So yes, definitely you can score full marks for the questions that appear from this dental anatomy and dental histology if you are a little bit careful. All right. Yes. So let's start with dental anatomy. Identify the age of the patient from the image given below. Yes. Is the patient like 8 years or plus or minus 9 months or 7 years or 6 years or 5 years? All right. So if you look at any of the recent NEET MDS question papers, definitely you can see one age estimation question from dental anatomy. All right. The age estimation questions are like a favorite of examiners for the NEET MDS exam. Uh, for the past 5 to 6 years, every NEET MDS paper has a minimum of one age estimation question. They can give an image like this and ask you to identify the uh, age of the patient, or sometimes they can also give an OPG picture, okay, an OPG image, and ask you to identify the age of the patient. Now, this question, this image-based question was asked in the recent NEET MDS 2025. In the NEET MDS 2024, yes, the question was based upon an OPG image. Okay, you are asked to identify the age of the child patient based upon an OPG image. So this time it is comparatively easy because this image is taken straight from the Wheeler's textbook of dental anatomy. All right. So this image, if you had gone through the textbook at least once, you will definitely remember this picture. All right, so this is comparatively yes. Yes, Dr. Pooja Kumari, you are right. Answer is option D. Yes. So let's have a look at the picture or the image again. All the blue colored teeth, they are the deciduous dentition, and the white colored teeth, they are the permanent dentition. So as you can see, all the deciduous teeth are still in the oral cavity. They had not started shedding. All right. So that's one of the major clues. They had not started shedding. Okay. So definitely the patient is below 6 or 7 years because the first two to shed will be usually the lower central incisors, and it usually happens around like in between like 6 to 7 years of age group. All right, so all the teeth are still there, all deciduous teeth are still there in the oral cavity, and shedding has not yet started. So definitely the patient is somewhat like below 6 to 7 years like that. And look at the permanent first molars. Okay, look at these permanent first molars. They have not yet erupted into the oral cavity. Okay, that is another major clue. They have not yet erupted into the oral cavity. So that shows that the patient is below 6 years, because usually the eruption time of the permanent first molars is like 6 years of age. Okay, so they have not yet erupted into the oral cavity. And look at the crown of the permanent incisors. Okay, the central and the lateral incisors, look at their crowns. Okay, their crowns are completed. Okay, so their crown completion usually happens by 4 to 5 years. So we can predict the patient age is like less than 6 years, but not less than 5 years, like that, not less than 4 years, like that. Okay, so out of the options given, the best option we can choose is option D, 5 years plus or minus 9 months. Okay, so this is how you can arrive at the answer for age estimation questions. Okay, so another clue is to easily tackle these age estimation type of questions is look at the teeth that had erupted last into the oral cavity. All right, so that teeth will determine the age of the patient. Okay, so that's another tip that you can use for such age estimation question. Now, how you can tackle such age estimation questions? There is a chronology charts. Okay, for the deciduous teeth and for the permanent teeth also. Okay, as you can see, this is the chronology chart for the deciduous teeth, which is given in the Wheeler's textbook of dental anatomy, and this is for the permanent dentition. Okay, take a printout of this chart, or if you want to make a table make a table of yourself, then you can do that. Okay, draw a table and then stick it in near your study table. Okay, where you can see them daily. Okay, so when you see them and watch them daily, it will definitely go into your visual memory. Okay, it will stay there. So somewhat these age estimation questions will be much more easier for you, especially if you look at this eruption time and the shedding time, like that. All right, that's one way. And here in this table, if you look at it, it's full of numbers. Okay, so numbers can confuse you. So to make things much easier, there are flashcards also available in the Wheeler's textbook itself. There are flashcards like this for the deciduous dentition, for the mixed dentition period, and for the permanent dentition. Okay, deciduous dentition and permanent dentition, it is somewhat easy to predict the age, but mixed dentition period. Okay, the mixed dentition period is another favorite of the examiners, from where the age estimation questions are usually asked. Okay, because some of the permanent teeth are in their eruption stage, some of the deciduous teeth are in their shedding stage. So you will be finding both the permanent teeth and the deciduous teeth during this mixed dentition period. All right. So, yes, that can get confusing also. Okay. So, for along with the table, you can also use flashcards like this. Okay. And look at it. Okay. Which all teeth are getting erupted at 3 years, or like which all teeth are getting erupted at 6 years, 7 years, like that. Have a look at these flashcards also. Okay. It will be very helpful for you in tackling such age estimation questions. All right. Yes. Next question. Most common accessory cusp that is present in the mandibular molars is. Okay. This is also a recent NEET MDS 2025 question. So, which of the following is the most common accessory cusp that is present in mandibular molars? Okay. We all know that the most common accessory cusp that is present in the maxillary molar is cusp of Carabelli. So, yes, that is ruled out. Then dens evaginatus. Okay, dens evaginatus is an accessory cusp that is present in the premolars. Okay, between the buccal and the lingual cusp, it is present in the central. Okay, it is also called a central cusp. Okay, so that is also ruled out. Now the remaining options are protostylid and metaconic. Okay, so which one will it be? Is it protostylid or metaconic? It is actually option A, protostylid. Okay, so let's see what this protostylid is, what this metaconid is. Like I had already mentioned, cusp of Carabelli, it is the axillary cusp that is located on the mesiopalatal surface of the maxillary molars, as you can see here in this image here. Okay, this is the cusp of Carabelli. Then we have the protostylid. This protostylid is the most common accessory cusp that is present on the mesiobuccal side of the mandibular molars. Okay, you see the accessory cusp here. Yes, that is called as protostylid, and it is one of the most common accessory cusp that is present for mandibular molars. Okay, so yes, the answer is protostylid only. Then dense vaginatus, like I had already mentioned, you can see here an accessory cusp that is present between the two major cusps of the premolar. It is also called as tuberculated premolar or Lyong's premolar. Okay, this premolars with such accessory cusp, they are also called as tuberculated premolar or Lyong's premolar also. Okay, so that is dense evaginatus, which is most commonly seen in the premolars. Okay, not the molars. Okay, so that's ruled out. Then metaconate. Okay, so what do you mean by this metaconate? Metaconate is, we cannot say that it is an accessory cusp. Okay, it can be considered as the mesiolingual cusp of the mandibular molars in most of the mammalian occlusion. Okay, not just the human dentition, but in most of the other mammalian occlusion also, this mesiolingual cusp of this of mandibular molars in the mammalian occlusion is called as this metaconate. Sometimes like yes, triangular shaped teeth or tubercular shaped teeth can be seen, and usually the upper teeth, they are called as the metacones, and the lower teeth, they are called as this metacones. Okay, so know the term, different terms that are used for different occlusions. All right. Yes. The next is the cusp that contact opposing teeth during maximum habitual intercuspation are called. What are those cusps called? Are they called non-functional cusp, or are they called stamp cusp, or are they called non-holding cusp, or are they called both non-functional or and stamp cusp? What can it be called? Yes. Any ideas? Any guesses? It is called as option B, stamp cusp. So let's see what this non-functional cusp is, non-holding cusp or stamp cusp is. Okay. So the cusp, okay, in occlusion, this cusp can be divided into two types. Okay. In occlusion, this cusp, based upon their function, they can be divided into two types. We have the centric holding cusp or the functional cusp or the working cusp or the supporting cusp or the stamp cusp. Okay, so these are all the same terms for this centric holding cusp. Okay, or the supporting cusp. Okay, then we have the other type of cusp which are known as the non-supporting cusp or non-functional or balancing cusp or shearing cusp or guiding cusp. Okay, so these are all the other names for this non-supporting cusp. Okay, so we have the functional cusp and the supporting cusp. Okay, so or we have the supporting cusp and the non-supporting cusp. Okay, so which cusp are usually regarded as supporting cusp and which cusp are usually regarded as non-supporting cusp? Okay, so supporting cusps are the ones which bear the maximum load. Okay, when in occlusion, these cusps bear the maximum load. Okay, they are the ones who maintain the vertical dimension of the face and they are the ones who contact the opposing foci or the marginal ridges also. Okay. They are the ones who help in mastication and for stability. Okay. So such cusps are called as the supporting cusp. Usually the supporting cusp will be very broad and rounded. All right. Okay. So the supporting cusp are usually the mandibular buccal cusp and the maxillary lingual cusp. Okay. The opposing cusps in occlusion. That is the mandibular buccal cusp and the maxillary palatal cusp or the lingual cusp. Okay. So they are the supporting cusp. They'll be usually broad and rounded in nature also. All right. Then we have the non-supporting cusp. Non-supporting cusp are mainly, their main function is to guide the mandibular movement. Okay, that's their main function, just to guide the mandibular movement. Okay, and it protects the soft tissues, and but it does not bear the like the vertical load also. Okay, it's just for guidance for the movement of the mandible. That's it. No other functions are there. Okay, so such non-supporting cusp will be usually very sharper, like this, very sharp and narrow. Okay, so which are the non-supporting cusp? The maxillary buccal cusp and the mandibular lingual cusp. They are the non-supporting cusp. Okay, so I think you got an idea about the supporting cusp and the non-supporting cusp. These supporting cusp are the or the functional cusp. They are also called as the stamp cusp, whereas this non-supporting cusp or the non-functional cusp, they're just for the guidance. All right. Okay. So how you can remember? Okay, it's easy to get confused between the supporting cusp and the non-supporting cusp. So just remember this mnemonic for the supporting cusp alone. Okay, remember the mnemonic FLUP. Okay, FLUP means the facial lowers. Facial lowers means buccal cusp of mandibular teeth and palatal cusp of the upper teeth. Okay, just remember as FLUP. Facial surface of the facial cusp of the lowers and the palatal cusp of the uppers. Okay, they are the supporting cusp. Just remember like that. Okay, just the other ones will be non-supporting cusp. Okay, so yes, try to remember like this. Then the next most commonly asked question, mesiolingual developmental groove is present in. Okay, there are like special anatomies, like anatomical structures that are present in different teeth, which are like really, really important because these anatomical structures are the ones that differentiate one tooth from another. Okay, so these structures are really important. Either they can give a straightforward question like this, or sometimes they can give an image. Okay, it can be converted as an image-based question also. They can just give an image and mark that particular structure in the tooth and ask you to identify this anatomical structure is present in which tooth. Okay, so you can expect the question like in any way. Be prepared for that. So this mesiolingual developmental groove, again, a recent NEET MDS 2025 question. It is present in which tooth? Is it present in maxillary first premolar or maxillary second premolar or mandibular first premolar or mandibular second premolar? Yes. So yes, the answer is yes, Dr. Pooja, you're right. The answer is mandibular first premolar. Okay. So this mesiolingual developmental groove is the groove that is present here. As you can see, the marked one here. Okay. So it is actually, this groove is actually a line of demarcation between the mesiobuccal lobe and the lingual lobe. Okay. It actually starts mesial to the lingual cusp and then extends occlusogingivally towards this mesial surface. Okay. So yes, it is one of the main distinguishing feature between the mandibular first premolar and the second premolar. Okay, so if you look from the occlusal view also, it will be very evident. Okay, this mesiolingual developmental groove will be very evident like this. Okay, so that is the mesiolingual developmental groove, and other grooves are also present, like the mesiobuccal triangular groove or the distobuccal triangular groove and the central developmental groove, which is present here. Other grooves are also present, but this one is the most important because it is the one that distinguishes this mandibular first premolar from the second premolar. Okay, so do not get confused. This is present only in the mandibular first premolar. Okay, present very prominently in this mandibular first premolar only. Okay, so sometimes while looking at the occlusal view, because of this mesiolingual developmental groove, it usually gives the occlusal surface like a snake eye occlusal pattern. Okay, so this snake eye occlusal pattern is also usually seen in this mandibular first premolar only. Okay, yes. Now, other than this, okay, there are some other important anatomical features that you should know. The first one is the mesial marginal groove. Okay, so this groove that extends from the, it is also a developmental groove that crosses this mesial marginal ridge here. Okay, so this is this mesial marginal groove. Okay, it usually extends from this occlusal surface and it crosses this mesial marginal ridge and it goes into the mesial side. Okay, so this groove is present only for maxillary first premolars. Okay, so this maxillary first premolar has two distinguishing features to distinguish it from the other teeth, like the mandibular first premolar or the maxillary second premolar. To distinguish it from the other teeth, it has two major anatomical features. The first one is this mesial marginal groove. Okay, so this mesial marginal groove, it usually extends from this occlusal surface and just cross the mesial marginal ridge and goes to the mesial side like this. Okay, so this mesial marginal groove is very important. And on the mesial side also, there is a developmental depression that is most commonly seen in the from the contact area till the root bifurcation region. Okay, so this developmental depression is also a characteristic feature of maxillary first premolar only. Okay, so that is called as the mesial developmental depression. Okay, so where this mesial marginal groove extends, at that side itself, you will be able to see a mesial developmental depression like this. Okay, so these two are the main characteristic features of maxillary first premolar. Okay, they can give an image like this and mark it like this and ask you to identify the like in which tooth you will be seeing such anatomical structures also. Okay, so you must be prepared for that. And then there is another groove that is present in the maxillary lateral incisors, which are called as the palato-radicular grooves. Okay, so the grooves that are seen here, yes, they are the palato-radicular grooves. Okay, these palato-radicular grooves are also developmental grooves that are mainly seen in the palatal surface of the maxillary lateral incisor. It usually extends like below the cingulum region, and it can extend till the root end also. Okay, so based on that, there is like the grade 1, grade 2, grade 3 of palato-radicular grooves. The grade 1, only like 1/3 extension till the root will be there. Grade 2, middle third extension till the root will be there. Grade 3, it will like extend till the root end. Okay, so such grooves are called as the palato-radicular grooves. Okay, just like the name suggests. It will be present in the palatal region and it can extend into the root region. Okay, so that those grooves are called as the palato-radicular grooves, and they are a characteristic feature of maxillary lateral incisors. Okay, so these are some of the important anatomical structures that you should definitely study in dental anatomy. Okay, the next question. According to Verducci classification, which type of pulp canal morphology is shown in the given image? Is it type 1 or type 4 or type 3 or type 2? Okay, so again, an image-based question. They can ask from directly from an image like this, or they can give an IOPA picture. Okay, they can give an IOPA picture and ask you to identify the pulp canal morphology. Okay, so this was asked in the recent NEET MDS 2024 question paper. And yes, I think other than this image was given, or like IOPA image was given, I don't actually remember, but yes, this was the question. Okay, so according to the classification, which pulp canal morphology is shown here? Is it type 1 or 4 or 3 or 2? Yes, Pooja, you are right. It is type 4. Okay, so in around like in 1974, a researcher called Bertucci, he used around 200 maxillary secondary molars, and he stained their pulp cavities with dye to understand their root canal morphology, and he observed different types of root morphologies. Okay, so according to his classification, there are 8 types of pulp canal morphology, and the type 1, it is the single canal from the chamber till the apex. Okay, only single canal. Type 2, there is 2 separate canals leave the pulp chamber, but just before, just short of the apex, they join together and form one canal. Okay, then we have the type 3, which where the only one canal leaves the chamber but divides into 2 in the middle, and they again join together just short of the apex and exit as one canal. Okay, type 4 is the easiest one. They begin from the pulp chamber as 2 and end as 2 itself. Okay, so that is type 4. Type 5, they begin as 1 from the pulp chamber and divide short of the apex and like exit as 2 canals. Okay, type 6 is uh, again 2 separate canals, then they join in the middle and then they again separate. Okay, type 7 is again one canal leaves the pulp chamber, then it divides and then rejoins again in the body of the root, and finally they redivides into 2 distinct canals just short of the apex. Okay, type 8 is another simple one. 3 canals leave the pulp chamber and 3 canals exit. Okay, so you can draw a table like this for easy identification of this pulp canal morphology. The type 1 will be 1 canal, type 4 will be 2 canals, and the type 8 will be 3 canals. Okay, just write this along, and other things add with 1, 2, and 1. Okay, try to remember it as 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, and 2, 1, 2, 1. Okay, 7 will definitely have 4 types. Okay, 4 numbers will be definitely there for the 7. Okay, so just try to remember it by drawing a column or drawing a table like this. All right. Yes. Now coming to oral histology. Okay. So oral histology, sometimes like majority of the questions can be asked from oral histology rather than the dental anatomy. And definitely there will be questions from development of teeth, and oral mucous membrane. Okay, and salivary glands. Okay, these 3 topics are the real favorite of examiners. Like 1 or 2 questions can be definitely there from these topics. Okay, so the first question, the buccopharyngeal membrane is formed by, is it formed by ectoderm alone, or mesoderm and endoderm, or oral ectoderm and foregut endoderm, or oral endoderm and foregut ectoderm? Okay, so how is this buccopharyngeal membrane getting formed? Yes, this is also a recent NEET MDS question. So the buccopharyngeal membrane, it is usually formed by the oral ectoderm and the foregut endoderm. Okay, so during the intrauterine life, around like 3 weeks of the embryonic life, usually the neural plates start getting formed, and the neural folds start happening, and there will be neural crust cells. These neural crust cells will start migrating into the head and neck region. Okay, so these neural crust cells are considered as the fourth embryonic layer because it is what initiates the developmental process in the head and neck region. Okay, so around this last of this third week or the beginning of the fourth week, what happens is that the embryo will somewhat look like this. Okay, the embryo will look like this. Okay, the brain is developing and the heart is also developing. Okay, so there will be a cardiac bulge and there will be a frontal prominence also. Okay, and the gut is developing, and the primary oral cavity also, you can't say it as like a fully formed oral cavity, but yes, the primary oral cavity, which is called as the stomatodium, will be present. Okay, so this stomatodium will be separated from the future alimentary canal by a membrane. Okay, so the primitive oral cavity will be separated from the future alimentary canal with a membrane. Okay, so that membrane is called as the buccopharyngeal membrane. Now, the characteristic feature of this buccopharyngeal membrane is in the buccopharyngeal membrane, there will be no mesoderm. Okay, it will be formed only by two layers, which is the ectoderm and endoderm only. Okay, so you all know the three germ layers of the human body from where all the structures are getting formed. Okay, we have three germ layers. One is ectoderm, second one is mesoderm, and third one is endoderm. Ectoderm is the layer from which the outer structures like the epithelium, the skin, hair, nails are all getting formed from this ectoderm. Then we have the mesoderm, which mainly forms the muscles. Okay, then the endoderm. Okay, the internal organs, they are formed from this endoderm. Okay, so the characteristic feature of this buccopharyngeal membrane is that it has no mesoderm. Okay, it is formed only by ectoderm and endoderm. Okay, ectoderm of the oral cavity and endoderm of the foregut or the future alimentary canal. Okay, so yes, buccopharyngeal membrane is formed by only these two layers. Okay, by around like around the end of the fourth week or by the end of beginning of the fifth week, what happens is that this buccopharyngeal membrane will break and the connection between the stomatodium and the future alimentary canal is established. Okay, so once the connection is established, that's when the tooth formation starts happening. Okay, so this rupture of buccopharyngeal membrane is an important event for tooth formation also. All right, yes. The next question, stratum germinativum includes. Okay, what does stratum germinativum means? Is it stratum basal? Is it another name for stratum basal? Or is it like stratum corneum and stratum granulosum together, or stratum granulosum alone, or stratum basal and parabasal spinous layer? Okay, so what is this stratum germinativum means? Okay, so as you know, we have two types of epithelium, non-keratinized epithelium and keratinized epithelium. This non-keratinized epithelium has usually three layers and the keratinized epithelium has four layers. Okay, so let's see what those layers are. So these are the layers of the keratinized epithelium. One is stratum basal, which is the basal layer. Okay, so these pink colored cells, yes, they form the stratum basal. Then above that, we have stratum spinosum. Okay, so these purple colored cells, yes, they are the stratum spinosum. Okay, then at the top of stratum spinosum, we have the stratum granulosum, which are these blue colored cells. They form the stratum granulosum, and the topmost layer, it is formed by stratum corneum or the corneal layer. Okay, so these are the four layers that you see in keratinized epithelium. Okay, so what do you mean by this germinative? Okay, stratum means it's the layers. Okay. The another term for this stratum means it is stratified, means it is layered one above the other like that. Okay, that's called as stratum. What do you mean by germinative? Okay, just like the germ layers we had already discussed, these germ layers are the structures from where all the organs or all the structures of our human body are forming. Okay, just like that, the stratum germinativum means it is from this layer all the upper layers are getting formed, or all the cells for these upper layers are getting formed. Okay, so they are called as this stratum germinative. Okay, so which all layers are included under this stratum germinativa? It mainly indicates stratum basale. Okay, so this basal layer together with the parabasal spinous layer. Okay, parabasal spinous layer means the spinous layer that is just above the stratum basale. Okay, so they are called as this parabasal spinous layer. Okay, so this basal layer together with the parabasal spinous layer. Parabasal spinous layer means the spinous layer that is just above this basal layer. Okay, so these two layers, they are together called as this stratum germinativum. Why they are called as stratum germinativum? Because these two layers in the epithelium, they have high mitotic rate. High mitotic rate means the cells will be continuously dividing again and again and again. Okay, they have like high proliferation capacity. Okay, high mitotic activity will be seen in these cells. Okay, so they continuously produce new keratinocytes again and again and again. Okay, so that's why they are called as the stratum germinativa. Okay, so stratum germinativa means it is mainly representing the basal layer together with the parabasal spinous layer. Okay. Yes. Next question. Which among the following is not a cell-to-cell junction? Okay. Is it desmosomes or hemidesmosomes or tight junction or adherence junction? Okay. Always study oral histology before you study oral pathology. Okay. Because once you understand these concepts behind oral histology, then only the oral pathology will be much, much easier for you. Okay. So, uh, just like we what to say just like we build a house by like stacking the bricks together and putting cement in between that, the cells are usually held together with the help of such cements. Okay, so these cements are called as the junctions when it comes to the cellular basis. Okay, so these cell junctions can be of three types. Okay, we have occluding junctions. Occluding junctions means they are the tight junctions. Okay, they are also called as the sonular occludents. Okay, no substance can go between the cells if the tight junction is present. Okay, it is actually extremely tight. Okay, so they are the occluding junctions. Then we have the anchoring junction. Anchoring junctions means these are the junctions that held together. Okay, that helps in keeping the cells together. Okay, so such junctions are called as the anchoring junction. And the last type of junction is the communicating junction, or which are also called as gap junction. Okay, so they are the ones who actually help in the signaling and coordination and all. Yes, these communication junctions are the ones which help in. Okay, so here we are mainly we'll be mainly focusing on this anchoring junction. Okay, so how two cells can be anchored? It can be anchored with the help of actin filaments, or it can be anchored with the help of intermediate filaments. Okay, so these anchoring junctions, usually the connection between two cells can be maintained with the help of two types of filaments. One is actin filaments and the other one is the intermediate filaments. Okay, so the junctions that are formed with the help of these actin filaments, they are called as adherence junction and focal adhesions. Okay, adherence junction and focal adhesions. Whereas the junctions that are formed with the help of intermediate filament, they are called as desmosomes and hemidesmosomes. Okay, so what is the difference between desmosomes and hemidesmosomes? There are two cells. These two cells are held together by each other with the help of desmosomal junctions. Okay, there are two cells. These two cells are held together with the help of desmosomal junction. Now there is one cell and there is a basement membrane. Okay, so this cell should also have attachment with the basement membrane. Okay, then only the whole structure of that epithelium will stand like that. Okay, so the cell and the connection between the or the junction between the epithelium or the basal layer and the epithelial cell, that is called as hemidesmosomes. Okay, so to make things clear, I'll show you the picture. Okay, once you get the picture, it will be much more clear for you. Okay, so these are desmosomal junctions, the one between two cells. They are called as the desmosomal junction, and the one between the cell and the basement membrane. Yes, they are called as the hemidesmosomes. Okay, so in the question, it was asked which among the following is not a cell-to-cell junction. Okay, so tight junction, yes, they are between cells. Adherence junction, yes, they are between cells. Desmosomes, yes, they are also between cells. But these hemidesmosomes, no, they are not between cells. It is between cell and the basement membrane. Okay, so hemidesmosome is the right answer among the following. Okay. Now, in case of pemphigus vulgaris, okay, in case of pemphigus vulgaris, usually these desmosomal junctions are broken. Okay, so desmosomal junctions are the ones which connect two cells together. So usually these desmosomal junctions are broken. So that's why a split is getting formed in pemphigus vulgaris. Whereas in case of pemphigoid, okay, like in bullous pemphigoid, usually this hemidesmosomal junctions can be broken. Okay, so that's why fluid is getting accumulated between the cell and the basement membrane, and bullae is getting formed. Okay, so yes, the next question. The ability of the cementum to repair itself to re-establish the root outline is known as. Okay, is it called as functional repair, or is it called as physiological repair, or is it called as anatomical repair, or is it called as pathological repair? What is it called? So cementum, in case of like heavy occlusion or because of some kind of trauma or because of some kind of insult, what happens is the cementum can get teared. Okay, so when it get teared, it will result in cemental tears. Okay, cemental tears. So there are specialized cells that are called as the cementoblast, which help in repair of the cementum. Okay, so based on that, there are two types of repair. Okay, two types of cemental repair can be done. Okay, so what are those two types of cemental repair? One is anatomical repair and the other one is functional repair. Okay, so anatomical repair means here the whole defect is repaired, and here the whole whole the whole fault is repaired. Okay, if there is any tear or if any resorption like this is happening, that area is like completely repaired. So when we look at it after some time, it looks brand new. Okay, so that is called as anatomical repair. Okay, it is like complete cementum deposition is happening. Okay, new cementum is getting formed and it is getting deposited in that resorbed area, and the continuity of the root surface and this periodontal ligament attachment, they are all maintained just like what is there before. Okay, so that is called as anatomical repair. Then there is some other form of repair also, that is called as functional repair. Okay, in this functional repair, the whole resorbed area is not repaired. Okay, if we look at it, we know that okay, there is some kind of resorption has happened here. Okay, so because the cementum is not getting deposited as such in the root surface, just like the anatomical repair here, the new cementum is not getting deposited in the resorbed area. Okay, but there only like a few like a structure is getting repaired. But what is happening is that the periodontal ligament width, it cannot be increased beyond a point. Okay, the periodontal ligament width should be maintained. So to maintain this periodontal ligament width, what the body is doing is that this bone is creating a projection to that defected area. Okay, so the bone is creating a projection to that defect area and is maintaining the periodontal ligament width. Okay, so if you look at it, you will be seeing a bay-like defect here. Okay, in the root area, you will be able to see a depression or a bay-like defect. That will be very evident. Okay, whereas in the anatomical repair, it is like completely brand new. You won't even know that some kind of repair had happened there. But functional repair is not like that. Just for the maintenance of function only, the repair is done. But as such, the whole anatomy itself is not maintained or not repaired. Okay, so the bay-like defect will be still there, but to maintain the periodontal ligament width, what is happening is that the bone, the underlying bone is getting projected into that defected area. Okay, so this is a major difference between this anatomical repair and functional repair. So in the question, it was asked the ability of the cementum to repair itself to re-establish the root outline. Okay, so the root outline is re-established in case of anatomical repair only. In case of functional repair, look at this. The root outline is not re-established. Okay. So yes, that's a major difference between this anatomical repair and functional repair. Now, next question. Which of the following immune cell in oral mucous membrane also acts as an immune cell in the skin? Okay. Is it keratinocyte or Merkel cell or melanocyte or Langerhans cells? Okay. So before going into this question, you must know the two types of cells that are present in the epithelium. Okay. In the epithelium, we have keratinocytes. Keratinocytes are the cells which produce keratin. And then we also have some special cells. They are called as the non-keratinocytes. Okay. So these non-keratinocytes will be present in few amounts in the keratinized epithelium also. Okay. So these non-keratinocytes are like mainly four types. We have the melanocytes, the cells which secrete melanin pigment. Okay, they are called as the melanocytes. Then we have the Langerhans cells. Okay, these Langerhans cells are the major immune cells. Okay, these Langerhans cells are the major immune cells that are present both in the oral mucous membrane and in the skin also. Okay, the next one is the Merkel cells. Okay, Merkel cells are more like sensory cells. Okay, these Merkel cells will be always present near nerve endings. Okay, so any kind of sensation like pain or vibration or some kind of light touch, all these sensations will be carried, will be first perceived by the Merkel cells, and it will directly pass it on to the nerve fibers that are present below the epithelium. Okay, so that is the main function of Merkel cells. Then inflammatory cells like lymphocytes are also present. Okay, so the major cell, immune cell that is present in both the skin and mucosa, which helps in the immunity of the epithelium is Langerhans cells. Okay, so these Langerhans cells, they are also called as dendritic cells. If you look at the look at this Langerhans cell under a normal microscope, it will appear something like this. Okay, just like a starfish. Okay, so the star-shaped cells like this will be present in the spinous layer. Okay, so these are the Langerhans cells. These Langerhans cells will be present, usually present in the spinous layer, and it will appear something like a starfish. Okay, but these same Langerhans cells, if you look at it under the electron microscope, okay, so under the electron microscope, it will appear something like this. Okay, it will have a vacuolated nucleus and like rod or flask shaped granules. Okay, just like a tennis racket shaped granules will be seen. Okay, so these tennis racket shaped granules, they are called as the Beerbuck granules. Okay, so these Beerbuck granules are a typical feature of this Langerhans cells. Okay, the main function of these Langerhans cells are actually they are the ones that originate from the bone marrow. Okay, from the bone marrow they originate, and then they travel through the blood, and then they reach the epithelium, and in the epithelium they'll go and guard the spinous layer. Okay, in case of any attack by any foreign antigen or by any bacteria or virus or fungi or any particle, what happens is that they are the first cells to identify. Okay, so they are the first cells to identify. They are also called as antigen presenting cells. Why they are called as antigen presenting cells? Because they will identify that antigen and take that antigen to the underlying inflammatory cells like the lymphocytes. Okay, so they are the first ones to identify the antigen, and then they will present that antigen to the immune cells. That's why they are called as the antigen presenting cells. Okay, so they play a major role in immunity in both oral mucous membrane and in the skin also. All right. Yes. Next question. Floor of the mouth has which type of mucosa? Is it keratinized mucosa or non-keratinized mucosa due to origin, or non-keratinized mucosa because tongue has the ability to remove bolus from reaching the floor, or none of the above? Okay, so before answering this question, you have to know what are the types of oral mucosa. Okay, so based upon the function. Okay, remember this term, based upon the function, not origin. Okay, based upon the function only, the oral mucosa is divided into three types. We have the masticatory mucosa, lining mucosa, and specialized mucosa. This masticatory mucosa is the one that is present in the gingiva and hard palate. Okay, so the main masticatory forces are present in this transfer to this gingiva and hard palate mucosa. So that's why this masticatory mucosa is keratinized in nature. Okay, so the masticatory mucosa is keratinized. Then we have the lining mucosa. Lining mucosa means the mucosa that is present in all the other parts of the oral cavity. Okay, the one that are present in the vestibule, in the cheek, in the buccal mucosa, alveolar mucosa, and the floor of the mouth and soft palate and all, they have the lining mucosa. Okay, so this lining mucosa is usually non-keratinized in nature. Okay, because not much masticatory forces are going into that mucosa. Okay, so that's why they are called as they are made up of non-keratinized type of mucosa. Okay, and then at the end, we have the specialized mucosa also. The specialized mucosa is present in the dorsum of the tongue because the tongue has like papillae and taste buds are present. So that's why the dorsum of the tongue has specialized mucosa. Okay, so floor of the mouth, as you can see from this classification here, floor of the mouth has lining mucosa, that is non-keratinized mucosa. Okay, because of the function. Okay, because usually when we chew food, the food is not going into the floor of the mouth. Okay, the tongue is like mainly dealing with the bolus, and the tongue is mainly helping in the chewing process. It is not allowing the food to go into the floor of the mouth. Okay, so the floor of the mouth is made up of mainly non-keratinized mucosa itself. Now, in patients with aglossia or microglossia or hypoglossia, that is absence of tongue or like a small tongue, in cases like that, what is happening is that if you look at such patients, their floor of the mouth will be elevated. Okay, why the floor of the mouth will be elevated? Because there will be hypertrophy of the muscles that are present in the floor of the mouth. Okay, so when the tongue is not present, this floor of the mouth is getting adapted to the bolus, chewing process and the bolus formation and all. Okay, so then what happens is that this floor of the mouth mucosa, it is getting adapted to the function of the to the functions of the masticatory mucosa, and it is becoming keratinized in nature. Okay, so the floor of the mouth has non-keratinized mucosa because the tongue has the ability to remove bolus from reaching the floor. Okay, the not due to origin. Okay, if in patients who does not have tongue, this floor of the mouth is having keratinized type of mucosa. Okay, so that shows that it is not because of the origin, it is because of the function. This floor of the mouth is having this non-keratinized type of mucosa. All right. The next question, identify the structure that is marked in red in the given image from the cap stage of tooth development. Okay. So another development of teeth question and very important one, an image-based question that was asked in the recent NEET MDS 2025 examination. So development of teeth for the description purposes, you can divide it into three stages. We have the bud stage, cap stage, and the bell stage. Okay. So in the cap stage, you have like special structures that are present in the cap stage that are called as the transient structures. Okay. So these transient structures means these structures will be present only for a limited time in the cap stage. When this cap stage progresses to the bell stage, these structures will disappear. Okay, so such structures are called as the transient structures. Now, what are these transient structures? There are four types of transient structures. First one is enamel node, second one is enamel cord, third one is enamel septum, and fourth one is enamel navel. Okay, so let's have a look at these structures one by one. By like when the tooth formation it reaches the cap stage, when it gets advanced in the cap stage, what happens is that these this is the enamel organ. Okay, this cap shaped structure, that is the enamel organ. Then this is the dental papillae. This area is the dental papillae, and the surrounding region, it is called as the dental follicle. Okay, so at the center of this enamel organ or towards the base of this enamel organ, few of the cells, they starts getting condensed. Okay, these cells, they starts getting condensed and will form a knot-like structure. Okay, just like the thread knot we make. Yes, just like that, a knot-like structure is formed at the middle towards the base of this enamel organ. Okay, so that particular condensation of cells, which is resulting in this knot-like structure, is called as enamel knot. Okay, since it's present in the enamel organ, it is called as enamel knot. Now, when the in this enamel knot, what is happening is that lots of cells are getting divided and divided and divided, and lots of cell divisions are happening. Okay, so lots of cells are getting formed. Okay, so these lots of cells are getting formed, they are becoming crowded and they are moving up. Okay, they are moving up. Okay, so it is forming an extension. Okay, so it is forming a vertical extension. So this vertical extension of this enamel knot is called as the enamel cord. Okay, so if you look at this enamel organ, this layer, okay, that is seen in this outer region. This layer is called as the outer enamel epithelium, and this layer that is very adjacent to the dental papilla, they are called as the inner enamel epithelium. Okay, so this enamel coat, if it goes and touches this outer enamel epithelium, then this enamel organ is getting divided into two halves. Okay, this will be one half and this will be the other half. Okay, so this enamel coat which is going and touching the outer enamel epithelium, that is called as the enamel septum. Okay, why septum? Because it is dividing this enamel organ into two halves. Okay, so that's why it's called as enamel septum. Okay, now the point where this enamel septum touches this outer enamel epithelium. Okay, so this is the point where this enamel septum goes and touches this outer enamel epithelium. At that particular point, there will be a small depression present. Okay, just like the navel. Okay, so that's why it is called as enamel navel. Okay, so these four structures will be present only in the cap stage of tooth development, and the four structures are really important. There will be like a continuous proliferation of cells in the center of the cap stage, center of the enamel organ in the cap stage, and they are called as the enamel knot. It will form a knot-like structure. That's why it's called as the enamel knot. There will be vertical extension of this enamel knot, which is called as the enamel cord. This enamel cord, when it goes and touches the outer enamel epithelium, that is called as the enamel septum. And the point where this enamel septum goes and touches this outer enamel epithelium, a navel-like depression will be present there. That is called as the enamel navel. Okay, so as you can see in the figure, there it is, the cap stage is shown, and like this shaded region. Okay, this shaded region, it mainly denotes enamel knot. Okay, so this enamel knot is very much important for the developmental process of the teeth. It is actually acts as a designer also. Okay, it decides how the cusp morphology should be. Okay, so that is decided by this enamel knot. It is actually an important structure, even if it is, these are like transient structures. The function or the importance of these structures are really very significant. Okay. Now, next question. Von Ebner's gland is it a serous type of gland or a mucus type of gland or a mixer gland or a sublingual gland? What are these von Ebner's gland? Okay. We know the three major salivary glands, parotid, submandibular, and sublingual. We know their openings also. Okay, their duct names and where these ducts are getting opened. Okay, we have the Stenson's duct, Wharton's duct, and the Bartholin's duct are all present, and their opening regions are also, we have an idea. Okay, but there are something called as minor salivary glands also. Okay, so these minor salivary glands, they are usually named according to the location in which it is present. Okay, we have the labial glands, buccal glands, molar glands, which are also called as Karmal's gland, and palatine glands are also present. Okay, then in the tongue itself, there are like lots of minor salivary glands present. Okay, and each of these glands have their own specific name also. Okay, so these lingual glands are of mainly three types. One is the glands of Weber. Okay, so this glands of Weber is usually present near this lingual tonsillar region and somewhat in this lateral border of tongue and in the lingual tonsillar region. Okay, mainly in this lingual tonsillar region, you will be able to see the glands of Weber. Okay, so these glands of Weber are purely mucus type of gland. Okay, mucus type of gland means very thick secretion. Okay, mucus type of secretion, that is the very thick type of secretion will be there. Whereas the serous type of secretion means the secretion will be somewhat watery in nature. Okay. Then we have the serous type of lingual glands, which are the glands of von Ebner. Okay. So in the posterior part of the tongue, surrounding this circumvallate papillae, special type of minor salivary glands will be there. They are called as this glands of von Ebner. Okay. They are usually serous in nature. And in the anterior part of the tongue also will have like minor salivary glands, which are called as glands of Blandin and Nunn. Okay, remember these names, glands of Blandin and Nunn, and they are mixed type of gland. Okay, both mucus and serous type of secretions can be there. Okay, so these are the three main types of minor salivary glands that are present in the lingual region. Okay, at the posterior most area, we have the glands of Weber. Surrounding the circumvallate papillae, we have the von Ebner's gland, and in the anterior most portion, we have the glands of Blandin and Nunn. Okay, so this von Ebner's gland are a really important gland, especially during the newborn stage. Okay, in the newborn stage, these glands are really important because our like the digestive enzymes will not be very uh, the secretion of the digestive enzymes have not been well developed, okay, for a newborn baby. Okay, so this von Ebner's gland secrete a special type of enzyme which is called as the lingual lipase. Okay, so these lingual lipase has the ability to digest all the fats that the newborn babies take. Okay, so that is the major role of this von Ebner's gland. Okay, the next question, identify the structure that is marked with arrow in the image given below. This is enamel, this is cementum, this is dentin. What is this structure called? Okay, it is very evident from the image that it is cemento-enamel junction. Okay, so cemento-enamel junctions, what are the types of cemento-enamel junction and which type of cemento-enamel junction is shown here? Okay, that is the question. Okay, there is like the butt joint or the overlapping joint, or is it a decalcified section, or is it under polarized light? Okay, so these are the confusing type of options that you can get for the NEET MDS exams. Okay, is it the butt joint, or is it a decalcified section? Is it the overlapping joint, or is it under a polarized light or not under polarized light? Okay, so these such type of image-based questions can be asked from oral histology, and this image is taken directly from the 10K's oral histology textbook. Okay, so while learning the image-based questions, try to learn it from a standard textbook. Okay, if it's dental anatomy, go for Wheeler's dental anatomy textbook. Okay, if it's oral histology, go for 10K's oral histology. Okay, 10K's oral histology. That is the book you need to follow, because this is a recent NEET MDS question only, the one that is appeared in the 2025 exam. So this image is taken directly from the 10K's oral histology textbook also. So please try to like learn this image based question from standard textbooks itself. Okay, so let's have a look at the cemento enamel junctions. Okay, cemento enamel junction means the junction where the cementum and enamel is going to meet. Okay, so these junctions are of three types. We have the sharp junction or butt joint like this, then gap junction. Okay, the cementum does not meet enamel. Okay, and then overlapping junction. The cementum is overlapping the enamel. Okay, so the most common type of junction that is seen is this overlap junction. Okay, around 60% of the people will show this overlapping type of junction. The cementum, it goes and overlaps that of the enamel. Okay, the next common type is this butt joint or sharp junction. Okay, where the enamel ends, there the cementum will start. Okay, so that is called as this sharp junction or butt joint. Then the least common one is the gap junction, that is between the enamel and the cementum, a gap will be present. Okay, so that is called as the gap junction. Okay, then there is another rare form, a fourth type, where the enamel is going and overlapping the cement. Okay, so that is very rarely seen. Usually the cementum goes and overlap the enamel, but very rarely, sometimes enamel can come and overlap the cementum. Okay, so according to the image that is given, where the enamel is ending, the cementum is starting there. Okay, so it is a butt joint or a sharp junction. Now, is it a decalcified section or is it a polarized light? Okay, so for knowing that, I will show you uh, how this decalcified section will look like. Okay, so this is how a decalcified section looks like. Okay, you will be able to see the dentinal tubules. Inside the pulp area, you'll be able to see the fibers, and around it, you'll be able to see the bone structure, and the fibers also will be seen. Okay, so that's how the decalcified section will appear like. But here, look at the image that is given. Okay, the enamel is like shining. Okay, the enamel will not be present prominently like this in a decalcified section. Okay, because in decalcified section, we are using strong acids. Okay, so because of the strong acids, what happens that usually the enamel will be mostly lost. Okay, but here the enamel is present and the cementum is also present and it appears very bright also. Okay, like shining. Okay, so that is what you will see when you do a ground section. Okay, when you are doing a ground section, usually the hard structures are maintained as such. The enamel and dentine and cementum will all be present as such. And take this ground section and look at it under the polarized light of the microscope. Okay, this is important. When you look at a ground section under the polarized light of the microscope, you will be able to see such shining structures like this. Okay, the enamel will shine like this. Okay, so this is nothing but this is the ground section of the teeth under the polarized microscope. Okay, it is not a decalcified section. Okay, yes. So out of the options given, it is the butt joint or the sharp junction of the enamel and cementum under a polarized light. Okay. Now, what are Odland bodies? Are they modified heme particles or is it an enzyme, alkaline phosphatase enzyme? Or are they like modified Golgi bodies or are they modified lysosomes? What are Odland bodies? Okay, so let's see what are these Odland bodies. These Odland bodies, they are also called as keratinosome or they are also called as lamellar granules. Okay, so these are the Odland bodies, the ones that are marked by green arrows. Yes, these are the Odland bodies. These Odland bodies are produced by the Golgi bodies of the keratinocytes. Okay, so every cell will have Golgi bodies. These keratinocytes will also have Golgi bodies. These Golgi bodies in the spinous layer and in the granular layer, they produce something called as this keratinosomes or lamellar granule or this Odland bodies. Okay, so the main characteristic of this Odland body is that it contains an enzyme that is called as the acid phosphatase enzyme. Okay, so this acid phosphatase enzyme usually acts like a permeability barrier also. That is, it will not allow the foreign antigens to go deeper into the epithelium. Okay, it mainly acts like a permeability barrier also. So this Odland bodies was first described by George Odland, under whose name the name is given for his these bodies, and he first initially described these Odland bodies as mitochondria. Okay, it is some kind of mitochondria he told. but that is ruled out by Selby. He considered it as a kind of keratohyalin granules. Okay, the ones since it is present in the upper spinous layer and the stratum granulosum layer, the Selby considered it to be a keratohyalin granules. But there is another scientist who considered it as some kind of viral particle, which is also ruled out. And finally, now these outline bodies, after so many researchers, these outline bodies are now considered as a special type of lysosome. Okay, they are considered as a special type of epidermal lysosome. Okay, so outline bodies are nothing, but they are modified lysosomes that are usually present in the upper part of the spinous layer and in the stratum granulosum. All right. The next question. A 1-day-old child came with parents to the clinic. Intraoral examination showed a tooth in the mandibular arch. Is it a neonatal tooth or a natal tooth and it should be removed, or a natal tooth and no need for treatment, or neonatal tooth and must be extracted? Okay. So what can it be? Okay, so this is also a clinical based question that was asked in the recent NEET MDS 2025. So yes, let's have a look at and the difference between natal teeth and the neonatal teeth. The teeth that are present in the newborns, okay, at the time of birth itself. Okay, the tooth that are present in the newborn at the time of birth itself, they are called as the natal teeth. Okay, the teeth that arises within the first 30 days, that is within the first month of life, that is called as the neonatal teeth. Okay, know the difference between natal teeth and neonatal teeth. Natal teeth, the child will be already born with a teeth. Okay, with a tooth. Okay, so that is called as a natal tooth, whereas neonatal teeth means the teeth that arises within the first 30 days. Okay, that is within the first month of life, that is called as the neonatal tooth. Okay, so usually the mandibular incisors, okay, they are the most commonly seen natal teeth and neonatal teeth. And if the teeth is present, uh, generally it can produce some kind of difficulties during feeding and some kind of ulcerations like this also in the ventral surface of the tongue. Okay, so such ulcers that are present in the ventral surface of the tongue, it is called as the Riga-Fede disease. Okay, so for the Riga-Fede disease, like appropriate measures can be taken, like grinding of the teeth or like anti also creams can be also be prescribed. Okay, so yes, if it is mobile and if there is a risk for aspiration only, usually we extract this natal. Okay, otherwise we leave it as such. Okay, so that's the treatment that is usually taken for the natal teeth. So out of the options given, the most appropriate answer for this question is it is a natal teeth and there is no need for treatment. Okay, since it is a 1-day old child. Okay, 1-day old child means that the child has is born with the teeth. Okay, so it is a natal teeth and there is no need for treatment. Okay, let's wait and watch. If it is causing like extreme problems like the Riga-Fede disease or any other, if it is like mobile and there are like chances of aspiration, then only we will look for measures like extraction. Otherwise, we will leave it as such. All right. Yes. Yes. Any doubts? Yes, doctor. So if you have any doubts now, you can ask it in the chat box. Yes. Or if you don't, yes. Yes. Thank you, doctor. Yes. In case if you are like after reading the topic, if you are having any doubts, you can put it under this video or you can message me directly in the WhatsApp group. We'll definitely clear all your queries. Okay. So all the best for your NEET MDS preparations. Do well, keep learning, keep revising, and keep practicing MCQs also. All right. Yes. So that's all for today. We'll see you all in another session. So goodbye and good night. Bye.